Hello,
Yeah.
Ajay, can you hear me?
Yes.
अच्छा ठीक है, तो वीडियो इज कमिंग फाइन ना?
हाँ.
ठीक है.
Dr. Prashant, you can hear me?
Yes, sir. Yes, sir. You are audible, sir.
That's good. So my video is visible. You can see me?
Not yet, sir. Not yet. So video is not coming.
Oh, why not? Everything is good from my side. I don't know why it's not coming.
Sir, by any chance, sir, you are using Lenovo laptop?
No, HP.
Okay. So is there any key, sir, where you can, is there any key for with camera in your laptop, sir? Usually Lenovo laptop, there is one key. So, yes, sir. Now it is fine.
That's good.
Yes, sir. So, sir, before we start, sir, although session is already live, sir, but audience will subsequently join after, because session was supposed to at 5 p.m. So, sir, Ms. Ravisha Rena from our marketing team, she will give the corporate presentation for company profile, and then, sir, I will introduce you to the audience, and then, sir, I will hand over the session to you, sir. And
so we can start with the corporate thing because we are right on time. It's 5:02 only. So you
sure,
start.
Sir. Sure, sir. Sir, just wanted to check, sir, whether you wanted to share your PPT once, just to check.
Okay, do that. I'll share my slides with you. I hope you can see my slides.
Yes, sir. Complete visible.
Perfect.
So, sir, yes, sir. So now, sir, I will just share my presentation.
So I will stop sharing my screen. Okay.
Sir, just one more thing, sir. Sir, we have methylcobalamin and gabapentin in our combination.
Pregabalin,
So,
not gabapentin.
Sir.
I hope it is pregabalin.
Yes, sir. Yes, sir. Yes, sir.
Fine. No
okay,
problem.
sir. Okay, sir. So, sir, I will just share my presentation and then, sir.
The topic seems to be a little bit wrong.
Sir, topic any?
For diabetic neuropathy, na? Because your molecule was also that. Okay. If you can change it, it's good. If not, then okay.
No, sir. No issue, sir. No issue, sir. So what you have prepared, sir, you present, sir, that only.
It is foot care only, but it's about diabetic neuropathy.
Diabetic neuropathy. Yes, sir. I completely agree, sir. So it's just for the generalized topics, sir, we have kept it as the foot care and diabetes as a series of events, sir. But yes, sir, diabetic neuropathy completely. Yes, sir. Thank you, sir.
Good evening, everyone. I, Ravisha Rana, on behalf of Mankind Pharma, would like to extend a very warm welcome to all our esteemed delegates who have joined today and are present with us in this session of foot care in diabetes. I would like to welcome our very eminent and esteemed speaker of the evening, Dr. Ashu Rastogi. Before commencing the session, I would like to take this opportunity to take you through the journey of Mankind Pharma in this pharmaceutical industry.
Let's show you how you can.
Of medical fraternity, Mankind has completed 25 years in this industry and are still counting. At Mankind Pharma, our vision is to become the most admired Indian pharma company. We not only are named Mankind, but believe in serving it too. Thus, all our Mankind family has dedicated their one-day salary in Prime Minister Care Fund. Not only this, Mankind is ranked #1 in prescription market. We are ranked #4 value-wise. We have 19 world-class US FDA and WHO compliant manufacturing units. Besides this, Mankind has established its presence in 34 countries, including USA. We continuously strive to improve quality of life and nurture innovation. And towards that, our 3 basic principles are quality, affordability, and reach. Mankind Pharma is well represented in almost all therapy areas and has leadership in many. Mankind has a dedicated research facility focusing on new drug delivery system, biosimilars, and as well as in formulation segments. With this, I would again like to thank you for your continuous support and encouragement to us. And once again, welcome and thank you so much for joining us here in this session. Now, I would like to hand over the session to Dr. Prashant.
Thank you, Ravisha. And thank you everyone once again for this scientific session. Now it is my privilege to introduce you to our speaker for this session, Dr. Ashu Rastogi, sir. Dr. Ashu Rastogi is currently faculty in Department of Endocrinology. He is working as assistant professor at Department of Endocrinology, PGIMER, Chandigarh. He has published more than 60 research papers in indexed international and national journals. He is a recipient of Fellow of American College of Endocrinology, Fellow of Royal College of Physicians, Edinburgh. He has received Young Investigator Award by American Association of Clinical Endocrinologists, USA in 2012. Best Research Paper Award by US Endocrine Society in 2015. Best Research Paper Award by IWGDF, Hague, Netherlands, 2019. He has also received Professor B.R. Srivastava Oration at RSSDI 2017. Received A.R. Seth Award by Endocrine Society of India, A.V. Gandhi Award by Endocrine Society of India, and Outstanding Paper Award by US Endocrine Society, San Diego, USA. He is currently Vice President of Diabetic Foot Society of India and Treasurer of RSSDI Punjab chapter. He has been Principal Investigator for various Phase 3 and Phase 4 trials related to diabetes and diabetic foot. Now, with all this, I welcome Dr. Ashu Rastogi, sir, to take the dais. Sir.
Thank you, Dr. Prashant. And it's my definitely privilege and pleasure to associate with a topic of interest to me. So I'll be just sharing my screen. Okay. I'll share my screen. And I'll be talking on a very pertinent topic. I hope I am audible.
Yes, sir. Yes, sir.
Yeah, good. We'll start, and I'll be talking mainly about diabetic peripheral neuropathy and also the foot complications. And as Dr. Prashant and my other colleagues from Mankind have already apprised you that probably it would be a series of events related to mainly diabetic complications, which include diabetic neuropathy and also the foot complications. So going on to it, first topic that I like to cover, which is a very common and very pertinent in these times, is about peripheral neuropathy, because you know that almost 3/4 of the ulcers in our country are because of diabetic peripheral neuropathy, and that leads foot complications. So I'll be mainly talking about the clinical aspects rather than more of theoretical aspects, especially the things that you commonly see in your clinics and how you can manage that. So first of all, definitely, as Dr. Prashant was mentioning, I come from the northern part of our country in Chandigarh, from prestigious PGI. And this is my institute from where I belong. This is the entry gate of PGI, and this is the place where we have our research labs. So I'll be covering the topics, and I'll try to find and tell you some answers that are very relevant to you. First is that how common is diabetic peripheral neuropathy in a given patient of diabetes? How do we define peripheral neuropathy? Because that's again is a very challenging question, because you might see many patients who might complain of neuropathic symptoms, but unfortunately people don't know how to rule in or rule out diabetic peripheral neuropathy, and how to classify and what to exclude before diagnosing peripheral neuropathy, how to screen and assess for diabetic peripheral neuropathy, how to diagnose, and once you have diagnosed, you should know how to treat peripheral neuropathy, and then an association of diabetic peripheral neuropathy and diabetic foot. And finally, outcomes in neuropathic foot ulcers, because we have the largest database in the world about the patients of neuropathic foot ulcers, which are published data, and I'll share with you. And finally, we'll go on to the take-home message. Coming on to diabetic neuropathy, it's mainly the epidemiological aspects. You can see whether it is type 1 diabetes, this is the type 1 diabetes, or whether it is type 2 diabetes. The prevalence of neuropathy increases with age. So this is irrespective of the duration of diabetes. Now you can see this duration of diabetes, as it increases, the percentage of patients who have peripheral neuropathy significantly increases from 5 years to 10 years to 15 years to 20 years. So neuropathy is inevitable. So once it has occurred, and once the patient is diabetic, he is likely to have neuropathy. Moreover, the percentage of patients who have peripheral neuropathy also increases with age. So as the patient ages, neuropathy increases. As the patient diabetes ages, again the neuropathy increases. So you need to be cautious, and you need to diagnose your patients with diabetic peripheral neuropathy very meticulously. Interestingly, what this study shows that many of the patients usually don't complain of neuropathic symptoms, or even if they do complain, the people in the peripheral clinics don't have the facility for the diagnosis of neuropathy. So this shows that at the time of diagnosis in a peripheral clinic, in a primary care setting, almost most of these patients have peripheral neuropathy once they were subjected to certain tests which are required for diagnosis of neuropathy. So that means if you don't look into it, it will go undiagnosed. Coming on to the diagnosis, it is important that diabetic neuropathy is a diagnosis of exclusion. This is important. It's a diagnosis of exclusion. So you need to rule out certain disorders which are much more common, which can lead to neuropathy. And one common disorders is either smoking or even alcoholism, which is quite common in this part of the country in Punjab. So 50% of diabetic peripheral neuropathy might be asymptomatic, and so the patient in your clinic will not complain, but you need to do certain tests that I'll show in the future slides. And out of all neuropathy, distal symmetric polyneuropathy, that is also called DSPN, is the most common form of neuropathy. Unfortunately, if you don't recognize it, it can lead to insensate foot, which can lead to foot injuries, and finally, requirement of amputations. This is a classical classification of diabetic neuropathy. They classify into mainly three major types. One is a diffuse neuropathy, there is mononeuropathy, that is also called mononeuritis multiplexa, and radiculopathy. All these kind of neuropathy are seen in a given patient of diabetes. But out of all these, DSPN, that is distal symmetric peripheral neuropathy, is the most common. And the primarily small fiber neuropathy is the most common form of neuropathy that is seen. So it can be an autonomic neuropathy, which can be cardiovascular, gastrointestinal, urogenital, or pseudomotor dysfunction. So this all needs to be diagnosed in a given patient of diabetes. But remember, there are some other common neuropathies that are common in diabetes, but they are non-diabetic neuropathies, like compression neuropathies. Especially you might be knowing about carpal tunnel syndrome. This is common in hypothyroidism in obese patients, but this is again very common, around 3 times more common in a given patient of diabetes, which is not related to diabetes per se. But yes, they are seen. So these pressure palsies, that is carpal tunnel syndrome, and even for foot, we have tarsal tunnel syndromes, and we have quite a few patients who present with foot pain. That is because of the compartment or this entrapment of the posterior nerve. It can be CIDP. Again, this is very common, but unfortunately misdiagnosed if you don't do proper test, that is EMG or NCV for diagnosis, because it can be very well treated by some kind of immunomodulatory therapies. And acute painful small fiber neuropathies, that is treatment induced. Regarding the symptoms and signs of DSPN, it can be either large nerve fiber associated or small nerve fiber associated. So remember, small nerve fibers are usually unmyelinated nerve fibers or myelinated nerve fibers. They usually carry the sensation of nociception or the pain perception, and also the protective sensation. So if the patient has lost these, the patient will complain of burning kind of thing, because you might have seen patients who says, "Doctor, my foot are burning like anything," or they would have an electric shock like sensation. Unlike the symptoms because of large nerve fiber involvement, which mainly carry the pressure and balance sensations. So they usually present with numbness or negative sensations, or tingling or poor balance. How do you examine that? For small fiber, you definitely do a temperature sensation, either hot and cold, or a pinprick sensation. But for a large fiber, you do a vibration test. So we have vibrotherms or vibration biosthesiometer that can tell you about the vibration perception, and also 10-gram monofilament. So these are the tests that we do for testing all of these. Remember that some different terminologies are used in clinics regarding the evoked pain. Suppose this is a stimulus intensity. You give this much stimulus, so this leads to this much amount of pain. This is a normal sensation. But unfortunately, in a given patient, you might have hyperalgesia. Hyperalgesia means that you give just small amount of stimulus, but the patient perceives a very large amount of pain. This is called hyperalgesia. This is again because of aberrant firing of the neurons, which land at DRG or dorsal root ganglion, which is seen in patients with diabetes. On the other hand, you might see a patient in which you give so much stimulus, but unfortunately no pain or very small amount of pain is seen. So this is a hyperpathia. And this is very common in given patient of diabetes. On the other extreme, you have another patient in which no stimulus is given, but still he perceives a lot of pain, and this is called as allodynia. So you can have varied symptoms and varied evoked pain in a given patient with diabetes, which you should remember. Now, how common is diabetic neuropathy? As I told you, around 50% is asymptomatic. So in a given patient, after around 20 years of diagnosis, around 90% would have neuropathy if you properly diagnose it. 50% would be symptomatic, and the rest 40% would be asymptomatic. But yes, even after 20 years of duration of diabetes, 10% of people might not have neuropathy. And this is a very important slide, because as I told you that diabetic neuropathy is a diagnosis of exclusion. So you need to rule out certain disorders, especially the metabolic disease. And one amongst them, which is quite common otherwise in a general population, is thyroid disorders. Because you know that hypothyroidism can also be associated with neuropathy. Renal disease called uremic neuropathy can also be there. Systemic vasculitis, amyloidosis is also associated with neuropathy. Infectious disease like HIV, hepatitis B. This is very important, CIDP, chronic inflammatory demyelinating polyneuropathy, which mainly present with motor symptoms. So the patient would have difficulty in rising from the sitting position or rising from the chair. This is again a sign and symptom of neuropathy. But nutritional deficiency is quite common in our country, especially in vegans. You can have a B12 deficiency, pyridoxine deficiency, and if the patient is chronic alcoholic, you can have thiamine deficiency, which can also lead to neuropathy. So you need to screen your patients for the diagnosis of neuropathy. Now, when to screen? The American Diabetes Association says, even in the 2020 guidelines, they say that you have to screen for a given patient of diabetes right at diagnosis. On the very first day is diagnosed with diabetes, you should screen your patient for peripheral neuropathy. And if it is a given patient of type 1 diabetes, you can do it after 5 years, and then you can do annually thereafter. Now, this is very important that once the patient enters into a clinic, he knocks onto your door and he enters into a clinic. So just by looking at his few steps or gait, you can definitely say that the patient is having neuropathy or not. So just watch your patient while he enters into your clinic and sits on the patient's stool. You look at the posture, his velocity of walking, his step length, symmetry, cadence, and fluidity of movement, which just on simple examination or simple visual attendance, it can tell you that patient is having neuropathy. If the patient is having high stamping gait, it definitely suggests patient is having neuropathy, mainly sensory neuropathy. If the patient walks to your stool, but in between he loses his slipper, it's likely to be sensory as well as motor neuropathy. If he has foot drop, then you'll see the foot scraping the floor. If he walks with an ulcer without limp, that means he is not perceiving that ulcer. So it is severe sensory neuropathy. Another test which is again very useful, without any kind of instrument you can diagnose neuropathy, and a very reliable tool which has sensitivity of 80% and specificity again of 80% for diagnosing of neuropathy, mainly motor neuropathy. So what you do, you ask your patient to arise from the chair without using the arm, ask him to walk 3 meters, turn back, return back to the chair and sit down. Just you need to know how much seconds did it took for all this. If the score is less than 10 seconds, it is normal. But if it is greater than 20 seconds, it suggests that patient is having gait impairment. And in a given patient, if he is not Parkinson's or the other neurological disorders, it's likely to be diabetic neuropathy. Look at simple signs. If he's having these kind of nails that are dystrophic nails, if he has a callus, which is quite common in the metatarsal heads or in the grade 4, if he's having dry, cracked skin, or some deformities, like this is a given case of rocker bottom deformity, you can see Charcot foot. These are all signs of peripheral neuropathy. In addition, you can also see for muscle wasting. So there would be guttering here. You can see the muscle are wasted. So guttering would be there. There would be prominence of these, the phalangeal heads and formation of the bursa and bunion, and the muscle weakness would also be there. So you can have claw toes, you can have bunion toes, and you can have mallet toes, and all these are signs of neuropathy. Now, coming on to what implication does it have to have a diabetic foot? So if the patient is having sensory neuropathy, he loses its sensation. He will not feel any increased pressure over the foot. There is loss of position sense, and he will change his walking pattern, and he will have hyperpronated gait. If he is having motor neuropathy, then he'll have muscle imbalance, he'll have weakness, and he'll have deformities, he'll have change again walking pattern. So there would be hyperpronation and more of the first metatarsopharyngeal contact time. And all these lead to more pressure over the sole of the foot, which can lead to the formation of ulcers. So you need to know that how we can assess a given patient of neuropathy. Most important is you need to talk to the patient, take a proper history. Patient might not tell you symptoms. You need to ask. Ask about symptoms of neuropathy, like both the positive symptoms as well as negative symptoms. Positive symptom means those signs or symptoms which are not present in a normal patient, but an abnormal diabetic patient would have, like burning sensation in the foot. And negative sensation means that a normal person would have like perception of temperature, but in a given patient of diabetic neuropathy, he will not perceive temperature. So check for temperature sensation and pinprick sensation. Check for vibration sensation using a 128 Hz tuning fork, which checks for large fiber function. And annually, you should do a 10-gram monofilament test. Most of the clinics I have found that they don't have a simple monofilament, but this is very cheap and it could be easily used even with a small amount of training. And remember, electrophysiological tests like NCV, AIIMS, all these tests are not required. You need not to refer to a neurologist unless you are thinking some other grave disorders which is not diabetic neuropathy. This is from the recently updated American Diabetes Association 2020 recommendations. Just do a simple 5 clinical tests, do a monofilament, pinprick, 128 Hz tuning fork, angle reflex, and vibration that can tell you many more things just about a diabetic neuropathy. This is the patient during my I was teaching my residents. So this is the place on the foot where you need to put your monofilament. So this is a 9-hole monofilament of 5.07 thickness, equivalent to around 10 gram of linear force. You just touch like this. This should be a lateral touch. Just buckle it and then release it. So you test at these 5 sites and then you assess whether the patient can perceive that monofilament or not. This is our diabetic foot lab at PGI, where we have all automated instruments. This is a diabetic foot chair, and all this is a diabetic foot lab along with many instruments. And this is our computer. This is a reception desk. So in a single instrument, you can check for vibration perception, temperature sensation, the pain perception. And suppose you don't have all these gadgets, what you can do, this is a very interesting test which was developed by Dr. Gary Raymond from Southern England. And this is known as from the city of Ispwich, and this is therefore also known as Ispwich test. So you don't have any instrument, do not worry. What you do is just you sit beside the foot of the patient, touch your finger onto the patient's toes, and ask the patient while he's either closed whether he can perceive those touch of your finger or not. And by this, you can definitely check whether he can sense your finger touch or not. If there are more than 2 of the he cannot sense out of 6, that means he is having at-risk foot or neuropathy. It has a very good specificity of 90%, and this can be easily done even at the primary health centers in India. This is our study, which was published in 2011, just to compare all these tests, and we found out that the tuning fork is a very good test, which has a 99% specificity for diagnosis of neuropathy. Now, this is something advanced. I need to show you that there are some advances also, because most of these tests, like you take a vibration perception, you take monofilament, sometimes they have a low thresholds would be very high, and they might be positive in a late course. But you need to diagnose neuropathy very early, because you need to give some prophylactic footwear to your patients. So we need a very sensitive test. So people have found out that this corneal confocal microscopy is a test which can diagnose neuropathy very, very early. Remember, your cornea in the eyes is an avascular organ which is richly supplied by nerves. And all these nerves are unmyelinated nerve fibers. So these are very early in the course of diabetes, they are lost. So just by looking at the cornea by a simple instrument which are possessed by the ophthalmologist, we are doing the corneal nerve fiber density. And by this, we can tell that his corneal nerves are dying. So the density, you can see the nerve fiber density is decreasing. And as the nerve fiber density increasing, the severity of neuropathy increases. They say that this corneal confocal microscopy is very specific for the diagnosis of small fiber neuropathy, mainly diabetic neuropathy, and it's very useful for early identification of diabetic foot than any other modality. Now, coming on to the differential, because this is again very pertinent, I have seen many of the patients who are given sometimes wrong therapies because of a wrong diagnosis. Suppose a patient comes to you who had mainly the motor weakness, like as I said, that he is not able to get up from a sitting position. So this is quite common in patients with CIDP or chronic inflammatory polyneuropathy. Here motor deficits are more common, mainly in the proximal thigh region, as compared to diabetic polyneuropathy, which is mainly in the foot region. It is distal neuropathy. It is a length-dependent neuropathy. Here, ataxia is rare, but in CIDP, ataxia is very common, and it's not seen in focal neuropathies. You can very easily diagnose CIDP by either doing a CSF, where you will have an increase in the CSF protein, but more non-invasive test would be just doing a NCV. You will have majorly a demyelinating pattern as compared to mainly axonal pattern, which is seen in diabetic polyneuropathy. And making a diagnosis is important. Why? Because CIDP can easily be treated with steroids or IVIGs, where you can have a good response. But in diabetes, if it is diabetic neuropathy, you will not have response. So these immunomodulatory agents like steroids and IVIG are not useful for neuropathy. So therefore, you need to differentiate between these kind of neuropathies. And coming on to entirely different kind of neuropathy, sometimes it's very difficult to treat, because you might see your patient who complain, doctor, I'm having a lot of pain in the foot. I don't sleep at night. And even we have seen a patient who committed suicide because of severe neuropathic pain, which is worse at night. And this is mainly because of abnormality in the peripheral somatosensory system. Majorly, these symptoms are distal in the foot region or in the calf region. They are symmetrical. They are mainly nocturnal exacerbations. They are very sharp, shooting-like pain and burning pain, which disturb the quality of life of a patient, and even they cannot work. So they are usually associated with hyperalgesia, as I explained to you, and allodynia, that even without a painful stimulus, but you touch the foot of a patient and he'll cry with pain. So this is painful diabetic neuropathy. It impairs the quality of life, and it's very difficult to treat. Therefore, you should know how you can treat it. So what the guidelines suggest, that treatment is successful if you can just reduce the patient symptom by 50%. It is said to be successful treatment. But again, even this 50% is very difficult. I'll tell you how we can modulate it. What the guidelines suggest, that the first line of treatment by this American Association of Neurologists, or it may be ACE guidelines or AD guidelines, are pregabalin. So pregabalin is the recommended treatment for diabetic peripheral neuropathy. You can combine it with methylcobalamin, because again, B12 deficiency is quite common. Pregabalin, methylcobalamin is quite commonly available in our country. But if the patient is not responding to these kind of drugs like duloxetine or pregabalin, you can go on to tricyclic antidepressants like amitriptyline or gabapentin. You need also to remember some patient characteristics before choosing the drug, because it has been seen that if a patient is depressed, then mainly tricyclic antidepressants would be a better choice in a given patient of neuropathy. If the patient is obese, you will not like to give TCS because that can be associated with weight gain. It's better to give pregabalin. Pregabalin is also not recommended again because it can lead to weight gain. So duloxetine would be the better choice. If the patient is having anxiety disorder, duloxetine or pregabalin is a good choice. If patient is having sleep disturbances, you can choose any of these drugs. But if the patient is having predominantly some higher history of CAD, try not to give tricyclic antidepressants. In that context, duloxetine would be or pregabalin would be a better choice. If the patient is having very high glucose or high fasting glucose, probably duloxetine should not be given because it can lead to increase in blood glucose. You can give pregabalin, that is a reasonable choice. If the patient is having renal failure, duloxetine should be avoided. You can adapt dose of pregabalin, and if some drug-drug interactions are there, pregabalin is the best choice. This is again from the Neuro PSIG summary recommendation, which says that again you can choose pregabalin, but if they are not working, you can choose antidepressants. But you should know certain side effects. With antidepressants like amitriptyline, you know side effects like these symptoms like somnolence, constipation, dry mouth, nausea. If it is pregabalin, it can lead to weight gain. So we usually avoid in our patients who are having obese or who are having significant weight gain. They are on insulins. Opioids are commonly used because of their dependence, but yes, tramadol is sometimes needed when the patient is having severe pain and not responding to other drugs. So this is the crux of the treatment of painful neuropathy. What they say, you can start with either pregabalin or duloxetine or TCS. It just depends upon the patient characteristic, as I had already mentioned. Usually pregabalin is the choice that we usually give in a dose of around 150 milligrams. If the patient symptoms are not controlled, then we usually switch or add TCAs onto this. So this is the final part of my presentation. This is a link between the neuropathy and diabetic. As I was mentioning, diabetic neuropathy is motor as well as sensory, which if it is sensory, it can lead to loss of protective sensation. If it is motor, it leads to deformity. And you know that almost 2/3 of diabetic foot ulcers in our country, this is our own paper published in Journal of Foot and Ankle Surgery, are mainly neuropathic foot ulcers, and hardly 20% are neuroischemic ulcers. So remember that neuropathic foot ulcers are very common. You need to diagnose neuropathy, then only you can treat them. So this is the largest study till date published. This is from our own center, and there were 7 centers all across India. You can see from, and with our collaboration from the Dr. Edward Jude from University of Manchester in England and Dr. David Armstrong from University of California. And we had more than 4,500 patients of diabetic foot, and we followed these patients for quite a long time, of around median of 8 years. And what we studied that what is the amputation rate in these patients of neuropathic foot ulcers and what is the mortality. We found out as compared to any other given patient diabetic who has neuropathy but not foot ulcer, we found out that those patients who are diabetic neuropathy with foot ulcer, they die very early. You can see from this Kaplan-Meier curve as compared to a patient with diabetic neuropathy who does not have foot ulcer. So in our cohort, around 1/6 of the patients with neuropathic foot ulcer died as compared to only 3% in controls. And most common reason of death was coronary artery disease. So we suggested that a patient who is having neuropathic foot ulcer, you need to be very cautious. Screen your patient, treat your patient properly, otherwise you will lose the patient. Similarly, another manifestation of diabetic neuropathy is Charcot neuropathy. And I'll proudly say that this is again the largest cohort of Charcot neuropathy in the world, which we published in Acta Diabetologica from PGI Chandigarh. And this was the mortality data of 260 patients of Charcot. And we found out that patient, if is having Charcot and you miss that patient, it's likely that you'll again not see this patient because of increased mortality. So patient of Charcot have around 2 times more mortality as compared to a patient of diabetic neuropathy without Charcot. So overall, the odds ratio for death was 2.7%. So this is important to diagnose certain disorders in a given patient of diabetic neuropathy. So coming on to the conclusions, I would say that it's good to sit with your patient, spend some time with your patient, take a proper history, examine carefully, just rather than just scribbling upon the treatment for glycemic control. And remember, for neuropathy is a difficult diagnosis and difficult to treat because the best treatment in neuropathy is only slightly better than the worst. So if you can carefully choose the treatment for the patient, then it will do good. Early recognition of peripheral neuropathy through periodic screening is essential. Annual examination for peripheral neuropathy is very important, and you should carefully note the signs and symptoms if they are present, and treatment has to be very individualized depending upon the symptoms. If it is a symptomatic peripheral neuropathy, mainly with burning sensation, etc., pregabalin is a very good choice in a dose of 150 milligram. And remember, neuropathy is not only about the patient suffering, it can lead to development of ulcer, then it can lead to mortality, as I have shown in our prospective series, and then it can have a very poor prognosis for limb and life. So I hope that some points about neuropathy would be clear to you all. And back to you, Dr. Prashant.
Thank you, sir. Thank you, sir. It was really, sir, very nice lecture, sir. Sir, we have few questions, sir, but before I go to the audience questions, sir, I just want to understand, sir, one thing. I mean, sir, from the audience side also, sir, like diabetic neuropathy, we are all aware that yes, it is a complication and it should be treated. But still, if you feel, you will also, sir, agree with me, still in India, the management part of diabetic neuropathy is not as such that it should be. So what may be the cause? I mean?
Yes, absolutely. You're absolutely right, Dr. Prashant. And I started my presentation on the same very topic, because the diagnosis is sometimes difficult. Why it is difficult? Because it needs some time to spend with the patient. You need to take a proper history. Again, it will take around 3 to 5 minutes. Then for examination part, again, it will take 3 to 5 minutes. And then only you can treat your patient. So spending time with your patient is the key for success of the treatment of diabetic neuropathy. And you can you can diagnose neuropathy with a simple instrument. And as I told you, even if you don't have an instrument, you need to be aware of simple tests like Ispwich test that I was mentioning. That has been recommended by now all the neurological societies in the world. So you just need to just aware about all these things. So whenever a patient of diabetes enters to your clinic, remember he is patient as a whole. So it's not only about glucose, and glucose. It's about the patient eyes, it's about the patient nerves, it's about the patient kidney. So just keep a small pro forma into your clinics. Tick, tick, tick. You can make some points that I need to examine all these things, and then you will be able to diagnose neuropathy.
Thank you, sir. So, sir, is there any possibility, like, let's say, sir, like you said, like you suggested, a performer we can provide or doctors can keep at their clinic, and they can simply, each and every patient of diabetes patient, they can simply click and they can have a, I mean, it's a checkpoints kind of thing, and they can simply whether it is present or not present kind of.
Absolutely. So there's a predefined proforma also. We also have a proforma in our clinics, because this is a protocol in PGI that whenever a patient with diabetes enters our clinic, we always first ask history. So if some historical points are there, we ask this yes or no. Do you have this? Do you have this symptom? Do you have this? Do you have this? So once we are satisfied with the symptoms, then we go on to the next part that is called examination. Examination starts with just a visual inspection followed by some certain test. So in PGI, we have our fully functional diabetic foot lab where we have facilities for diagnosing neuropathy. So within maybe 2-3 minutes, we are able to diagnose these patients with neuropathy. So I think this is not a rocket science. It can be easily done even in peripheral health centers.
We just have to look at the foot of the patient.
Absolutely.
Thank you, sir. Sir, now the next question from the audience side is that, is there any preventive measure we can do for diabetes patient? I mean, from the start, day one, I mean, when a patient starts therapy, from day one, anything else we can do to prevent progression of diabetic neuropathy?
Absolutely. So the best evidence for the prevention of neuropathy and to prevent the progression of neuropathy comes from the UKPD study. Now, everybody knows about the UKPD study. That is the largest study till date, which shows that you can also prevent and as well as prevent the progression of neuropathy by doing intensive glycemic control. Now, by intensive glycemic control, I mean that you need to chase the glucose targets. And as ADA and ACE recommendation says, you should try to achieve HbA1c as close to 7% as possible. And this has been shown to prevent neuropathy. Second thing, we need to ask our patient to refrain from smoking, alcoholism, because these definitely can lead to worse prognosis in a given patient of neuropathy. And the third thing is about prophylaxis. Now, prophylaxis means neuropathy lead to foot ulcers. How you could prevent that foot ulcers is just by asking the patient for daily self-examination of foot. So whenever the patient goes to the washroom or in the bathroom to bathe, what he can do, he can just look at his foot, whether there is some abnormality, whether there is some kind of callus, whether there is some kind of swelling. Whenever he sees that, he can report to you so that you can give him some treatment. Now, what is that some treatment? That some treatment is prophylactic sandals. So these should be good cushioned shoes. So we can ask our patient ki kindly don't wear simple Hawaii chappals or those Punjabi jutis or these simple things that can make your things worse. So better to wear some good sandals which have a good cushion that is good for your foot and also for neuropathy.
Thank you, sir. So, sir, adding methylcobalamin to the patient's regime at the start, will it help, sir?
So regarding methylcobalamin, so methylcobalamin with pregabalin, now it is very commonly given because methylcobalamin deficiency is quite common. It's not only in the West, but also in India. Now, this is much more common in the vegetarians. Now, I presume that in India or Southeast Asia, the vegan diet is much more common. So B12 deficiency is also very common. So, and B12 deficiency is a very common cause and very common differential of diabetic neuropathy. So why not to give methylcobalamin along with a pregabalin? Now, another rationale for adding methylcobalamin is that B12 deficiency is again very common in metformin users. And we know that metformin is the gold standard for treatment of diabetes. So almost all a patient would be on metformin. So now EDA also says that you can do B12 levels in your patients, and if they're found to be deficient, you can supplement them. But unfortunately, B12 levels are very costly. So why do costly tests? Instead, just supplement them with B12, which comes at no additional cost than adding to pregabalin.
Thank you, sir. So next question is that for how long methylcobalamin can be given, sir? Or is there any guideline which says, I mean, after that?
Fine. So now how long can be given? So important is that usually the pregabalin is given until the patient are having symptoms. So if the patient having symptoms of neuropathy, you can continue pregabalin. So there is no dictum that you should stop by 1 month, 2 months, or 2 years, or 5 years. Whatever time the patient is symptomatic, you continue with pregabalin as well as methylcobalamin. And moreover, methylcobalamin toxicity is very, very uncommon. So even if you give a patient methylcobalamin in the maintenance dose that is present in these combination of this fixed dose combination of pregabalin and methylcobalamin, it will not add to any side effect or toxicity. So it can be very safely given.
And so what about neuropathic pain? So what may be the ideal choice of drug to start with?
So in our clinics for neuropathic pain, we usually start with pregabalin, and people have said that in India, unfortunately, people don't start with a proper recommended dose. Usually the standard dose of pregabalin is 150 to 300 milligram. But in India, if the patient is suppose lean and thin, who is having a weight less than 60, you can start with a small dose, 75 milligram. If it tolerates that, if it does not have somnolence, you can increase to 150 milligram and then on higher doses depending upon the symptoms.
Okay. Thank you, sir. So, sir, that was the last question, sir. So thank you very much, sir, for this entertaining session. And I hope all our audience must have really benefited from your point of discussion, sir. So from Mankind Medical Affairs team, sir, and marketing team, sir, I thank you for this session, sir. Thank you very much.
Thank you, Dr. Prashant, and have a nice day and have a safe time during this COVID epidemic.
Thank you, sir. Same to you, sir.